Great. Maybe we'll just start right now then. In 5 minutes. So I just, on behalf of Friends of Medicare and Public Interest Alberta, I want to welcome you all to tonight's webinar, Reimagining Seniors Care, a very timely and important conversation to be having during this pandemic and as we hopefully move out of it. How this evening is going to go, just a little bit of housekeeping, where Joel and I will be doing brief introductions of the work that each of our organizations does, and then we will pass it over to Rebecca Graff-McRae from the Parkland Institute, who has kindly agreed to moderate tonight's evening, and then we will have our two speakers, Pat Armstrong and Margaret McGregor, who have an incredible amount of experience around this issue. So we're very, very fortunate to have them with us tonight. If you have any questions throughout any of the evening, please fill out there's a question and answer icon at the bottom of your screen. I would encourage you to put your questions in there rather than in the chat, because in the chat we can't keep track of who's asking questions. So we'll try to answer as many as questions as possible throughout the evening. And if your question is not answered and you really want an answer, we will post both Pia's and Friends of Medicare's address, email address, and we will make sure that your questions get answered from each of the speakers if you have one. So thank you so much, like I said. And now I'm just going to turn it over to Joel to talk a little bit about Public Interest Alberta.
Thank you, Sandra. My name is Joel French. I'm the Executive Director at Public Interest Alberta, and we're very excited to be co-hosting the webinar this evening with Friends of Medicare. I am bringing you greetings from our Seniors Task Force, which is made up of 16 organizations, mostly representing seniors around Alberta. Most of them are smaller nonprofit organizations, and also belonging to our Seniors Task Force are the labor unions who represent workers that are on the front lines of seniors care, and that I know we all are expressing our gratitude to for the hard work that they're doing and the risk that they're putting themselves in caring for seniors, especially at a time like this. I do want to highlight a campaign that we've been running with Friends of Medicare that Sandra has mentioned, called Alberta Seniors Deserve Better. We'll post the campaign website in the chat. Specifically, there's an action page that Laura has just posted in the chat where you can sign up to call on the government to do better. And you can also get updates from us by signing up on that page. I do also want to say we are having masks printed for that campaign that will have the Alberta Seniors Deserve Better message on them. We haven't received them yet, but we'll have 500 masks coming over the next couple of weeks. So feel free to be in touch with us, or make sure you're signed up on our email lists to learn about those and learn how you can get them. And the Seniors Task Force has also put out a priorities document back at the beginning of October that lays out the directions the government should be going in Alberta when it comes to seniors, particularly seniors care. Right now, the government is doing a review of facility-based continuing care. And I know Public Interest Alberta and Friends of Medicare are both putting a high priority on not only telling our politicians what the future of continuing care should look like, but talking to Albertans about those things. And so we've put out some material that's just been posted today that is fresh, to help you, help guide you with some talking points and things that you should know before you send your message to the government and before you share that information with your networks. So if you follow that link Laura has just posted in the chat, that last one, you'll get information on that. And we really encourage you to engage in that over the next week and a half. You have a week and a half until the deadline. I'm really looking forward to the insights we're going to get from the speakers that we have today. We have a couple of the brightest minds in Canada when it comes to seniors care. And I know that we're going to have a really vibrant discussion with all of the passionate folks that are attending. I really want to express my thanks to everybody for being here. We know that you're here because you're passionate about the issues and you're motivated to do something about it. And I think that's what we're here for together. So looking forward to learning about things from our speakers and finding ways to do that. Alberta seniors certainly do deserve better from our government, and we're going to talk about how we can do that tonight. So on behalf of Public Interest Alberta, thanks so much to everybody for being here, and enjoy the discussion.
Thank you so much, Joel. Friends of Medicare, in the event that you're not familiar with the work that we do, again, on behalf of our members, we would like to thank you as well for joining us today in this very important discussion. Friends of Medicare is an advocacy organization that has for the last 40 years been promoting the protection and expansion of our public health care. And nowhere else, in no other area that we work in, within have we been witness to the impact that privatization has had on the care that we provide to our seniors. Over decades, we Friends of Medicare and seniors advocacy groups have been sounding the alarm over the issues in our seniors' care. And COVID-19 has definitely shone a light on the cracks within the system. But it has also provided us with the ability to see how we can reimagine a system that has for decades now left our seniors in not optimal situations. In Alberta, as of today, 978 of the 1,484 reported deaths related to COVID have been of seniors in long-term care facility or designated supported living facilities. And that's a huge number of our loved ones dying as a result of a system that has been created that has for decades now held profit over the actual care. And that's what we're here to hear about. We're here to learn from this experience, to learn from decades of research, and hopefully give us enough insight so that we can arm ourselves to move forward as we move out of this pandemic. We can't return to normal. Normal was not working for our seniors, and it's definitely become a challenge that we must all undertake to ensure that that the government and those that are making policy decisions around seniors care learn from this pandemic, and that the lives of all those that we have lost and continue to lose will have a meaning at the end of this pandemic. So I am now going to turn it over to Rebecca Graff-McRae, who is a researcher at the Parkland Institute. The Parkland Institute has done an incredible amount of work around the issue of seniors care and trying to understand the history as to how we got to the point in this province that we are currently face ourselves in. She is, Rebecca has completed her undergraduate and doctoral studies at Queen's University, Belfast, and her work talks extensively around the role of memory and commemoration in post-conflict transition, has evolved through a Faculty of Arts Fellowship at Memorial University, Newfoundland, and an SSHRC Postdoctoral Research Fellowship at the University of Alberta as well. She has previously worked with the Equality Commission for Northern Ireland and Edmonton City Council. So thank you so much for agreeing to moderate this evening's event. And now I turn it over to you, Rebecca. Thank you.
Thank you so much, Sandra. Thank you, Joel, and thank you to your staff as well for busily working behind the scenes to put this all together. I know that two of the voices that I have been determined to follow for the last year during this pandemic are here in this virtual room with me today, and that's Margaret and Pat. And so I feel very, very fortunate to be sort of on the sidelines here this evening, and maybe selfish enough to ask a few of my own questions as well. So I think we couldn't be in a better position to learn from their combined experience and insights on what really ought to be one of the most important issues that we're facing right now in this country and in this province specifically. So I can take a minute to introduce each of these very eminent researchers, and I will not be able to do justice to their CVs in the time that I have. So please know that this is just a very distilled version of all of their accomplishments, and I'll try not to smear the flattery on too much, but it's very deserved. So Margaret has won the coin toss. Margaret McGregor was a family physician for 25 years in the Vancouver area, and she's been an ongoing advocate for reform in primary and seniors healthcare. She's currently the Director for Community Geriatrics at the University of British Columbia Department of Family Practice, and a Research Associate with the UBC Centre for Health Services and Policy and the Vancouver Coastal Health Research Institute. Her publications on long-term care are, I would consider them canon. I'm certainly, I think I've cited about a dozen of them in my most recent report, which you might see in a couple of months. So I can't list them all off here at the moment. But most recently, she has been doing some very up-to-the-minute research on the impacts of COVID-19 in long-term care, specifically COVID-19 in long-term care homes in Ontario and British Columbia, and COVID-19 and long-term care facilities. Does ownership matter? With Charlene Harrington, which are both in the CMAJ. And also a piece in Policy Options, Time to Heed the Evidence on Public Funding for Long-Term Care, which I think are very crucial contributions to the conversation that our politicians and our policymakers need to be having at the moment. So all that said, I would like to turn it over to Margaret McGregor first.
Thank you so much. And I'm just going to try and see if the screen share works. Let's just, does it work? Yes? Can you hear me? Oh, hello. Can you hear me? Yeah, go for it. Okay, so thank you for inviting me to speak today. Before I begin, I want to acknowledge that I'm speaking from the unceded territory of the Musqueam, Squamish, and Tsleil-Waututh Nations here in British Columbia. And I'd like to use my 10 minutes to first just really review some basics about long-term care. And then after that, I'm going to briefly describe what we know about the research on facility ownership and quality more general, and then move into what we know already about the research on ownership and COVID and other drivers of how COVID's been playing out in long-term care. Now, I don't seem to be able to move this. That's a problem. Oh, there we go. Oh. So basic information, what is long-term care? So firstly, who lives there? And I think the main point I want to emphasize here is that in 2021, the residents in long-term care really are the most vulnerable members of our communities. So in order to qualify for long-term care in this day and age, you have to be very, very dependent on others to accomplish just the basic activities of daily living, like washing and dressing and feeding. And we call that dependency frailty. And it's usually often due to age, can be due to chronic medical conditions or a combination thereof, or in some situations, younger disabled people. But frailty, we know far more than age, is a huge determinant of longevity, and it predicts higher mortality much more than age itself. So how do we fund long-term care? Well, it's not part of the Canada Health Act, as many of us probably already know. So it's funded by a combination of public and private money. Public funds come from our tax dollar, and then there's a user pay portion that's often income tested, and it varies quite greatly by province. So that's on the funding side. So then how do we deliver the care? Well, again, because it's not part of the Canada Health Act, the delivery is through a mix. So some facilities are owned and operated by government, In Ontario, that would be the municipal care homes. Here in BC, it's something called owned and operated by health regions. Then the other two big entities that deliver long-term care are for-profit facilities, and they can either be sort of mom and pop owned, or they can be large multinational chains. And then there's the nonprofit sector. And so here in BC, the delivery is about a third government owned, a third nonprofit, a third for-profit. In Ontario, a majority of care is delivered in the for-profit sector, with the last, I'm going to say 2020 being by municipal care homes and the nonprofit sector. So it's a real mix, and that certainly has led to some of the challenges. So what do we know about the research on ownership and quality? Well, actually, there is a large body of literature that's been published really over the last 2 decades that relates for-profit ownership with inferior care. And that's on average. It doesn't mean that one for-profit facility is really bad. It's talking on average. This is the law of averages here. But generally speaking, research has found that when compared to nonprofit and government-owned models, for-profit facilities don't do as well. And the types of things that come up most commonly are pressure ulcers, rates of transfer to hospital and visits to the emergency room. And then one of the most consistent findings, of course, is that for-profit facilities hire fewer staff. And just to highlight this, just prior to the pandemic last year, our BC Office of the Seniors Advocate looked at how the for-profit and nonprofit sectors were spending their tax dollars, our tax dollars, and found that the for-profit sector failed to deliver 207,000 hours of care for which it had received funds in 2016-17 and 2017-18, compared with the nonprofit sector, which actually provided 80,000 more hours of care than it was funded to deliver. So it was actually subsidizing the amount of care. And that's not by an academic, that's by an independent office whose job it is to be the watchdog for quality issues in this sector for seniors. So what do we know about, this most consistent element is staff. What do we know about the research on staffing and quality? Well, again, there's a large body of literature that has shown that the higher the staff in general, the better the care. Where there's low staff turnover, there's improved care. And in fact, when staff is low, you're going to have higher turnover rates. And there's a very interesting article published by Ramage Morgan in 2006 that showed that when residents said they could identify at least one staff member with whom they had a relationship, it was related to positive self-perceived health, which again was related to lower mortality. So relational care is related to identifying staff who make a difference in the quality of health, self-perceived health, and the mortality of residents. So despite all this evidence, in most provinces, governments have relied on the private sector to expand long-term care beds. And that really goes across the board. It's hard for me to identify any provinces that haven't gone that route, although I would say in our own province, in the last few years, we've been trying to slowly reverse that. There's been a very consistent resistance to setting minimum staffing standards. There's been widespread subcontracting by facilities. So even nonprofit facilities may decide to subcontract to outside for-profit agencies. And workload assignments of 1 care aide to 10 to 15 residents, which is an assignment that far exceeds best practice recommendations, is very common. So that's the lay of the land into which this pandemic arrives. And we know that the virus spreads easily anyway in congregate settings. We know that there can be asymptomatic spread, where the most common route is through staff coming into facilities, either not knowing that they're sick or having to, and certainly in wave one, having to work when they're sick because they had no choice in order to provide a livelihood for their families, often working in multiple facilities, I should say, until the one site restriction came in. They arrive in a population that's highly prone to infection and that once infected are much more prone to severe disease. And then the staff in this context has to move quickly between residents to manage unsustainable workloads. They're expected to wash their hands, change their gowns, put on new gloves each time they move from one resident to another. And then when there's an outbreak, they often have to work short. So, you know, we've all heard stories about how staff or facilities are finding themselves with, you know, 50% of usual staffing complement when there's an outbreak or even less. So what do we now know about the research on long-term care ownership staffing in COVID? Well, interestingly, there's been a lot of research over the last year looking at that. So Charlene Harrington found that facilities with staffing levels under the recommended minimum had a 2 times greater probability of a COVID infection. A study has found higher nurse aid hours and total nursing hours is associated with a lower chance of outbreaks and fewer deaths. That's by Gorges and Konecka. And then a couple of researchers, Abrams and Stahl in Canada, found that for-profit facilities had a greater probability of more extensive COVID-19 outbreaks. And there's also been considerable research now showing that there's a greater probability of COVID-19 deaths in for-profit facilities compared to nonprofit facilities. So the same lines of evidence that we found with other quality measures we're now seeing play out with COVID-19 outcomes. So what are we finding beyond staffing and ownership? Because it's not just all about that. Well, there are other factors related to outbreaks and severity of outbreaks. There's some interesting research that's identified that the outbreaks are related to the prevalence of the virus in communities where caregivers live. Again, it makes total sense when the virus is being brought in by asymptomatic carriers. There's been research found around size of facility. So larger sizes tend to be associated with higher chance of outbreak. Shared accommodation is a factor that, again, is one of likely many others that we're going to continue to learn about. That said, ownership and staffing certainly float to the top as 2 potentially modifiable factors that policy can change. So in summary, COVID-19 has really highlighted that public investment in for-profit owned care homes is really no longer a credible policy option. It has highlighted the need for family supporting wages and working conditions. It's highlighted the need to end facilities subcontracting their services. And it's highlighted that it's time to now mandate resident to staff ratios consistent with the best evidence, and indeed 10% higher than that, given that we're still in pandemic conditions. And generally speaking, the consensus is for any care model, you need 10% higher staffing levels under pandemic conditions. Sometimes it even goes up to as high as 20 or 30%. And finally, we need to build models that reduce the number of contacts per resident for each staff member, which is also consistent with more relational care. So more relational types of care models where staff can care for a smaller number of people in a more holistic way is definitely something that I think we need to start looking at. So thank you very much. I'll end there and really look forward to questions.
Thank you so very much, Margaret. I feel like that's a whole year worth of very intense research in a difficult time, summarized into 15 minutes. And I know that gives us a really good foundation for trying to grapple with some of these complex issues. And we'll give Pat a minute here, and I'll give her an intro the best I can. So Pat Armstrong, as one of the most prominent voices in seniors care in Canada, and I can't even number all of the accolades that she has on her wiki page, so I won't try. She is a distinguished research professor in sociology at York University. She holds the CIHR chair in health services. She serves on the boards of the Canadian Health Coalition and Canadian Centre for Policy Alternatives. She has been named a fellow of the Royal Society of Canada and was also a contributor to their recent report on long-term care that was released in the summer. She has been recognized as one of the YWCA Toronto Women of Distinction and received the Ethel Mead Award for Excellence in Research in Public Interest from the Ontario Health Coalition. Pat's many publications, again, quite too numerous to list here, but her current projects include the SSHRC-funded Reimagining Long-Term Residential Care and the CIHR Healthy Aging in Residential Places. And most recently, she co-authored a manifesto to inform national standards for long-term care in Canada with Marcy Cohen, A Higher Standard. So thank you very much, Pat.
Thank you, Rebecca. I have to get a do wherever you found that description of my work. It looks like I have to update it. But thank you very much. And thank you all for being on this call, and certainly thank you for this invitation and for the people who organized it. And thank you, Margaret, for covering a lot of what I was going to cover. Not surprisingly, we overlap because for the last decade, Margaret and I have been involved in a project on reimagining long-term residential care that took us to 6 different countries to look at care there. And as Rebecca said, I've just finished a paper with Marcy Cohen and other people at the Canadian Centre for Policy Alternatives to try and move the agenda forward in terms of developing a national set of standards for long-term residential care. And what I want to do tonight is briefly set out those 7 standards we talked about so that we can have a discussion about it, and also talk about 5 other standards for a labor force strategy at the national level. And we can also talk about whether it should be national or not, but we certainly think it should be. And we think it should be a plan for long-term care that is understood to be part of a larger seniors strategy based on some foundational principles that we set out in that higher standards paper. So let me briefly talk about those 7 standards. The first one is access. As Margaret said, that what people pay and how they pay it across the country varies a great deal. But Martha McDonald's study looking at the systems across Canada said money really isn't the barrier for people going into long-term care. The barrier is we don't have enough beds. That's a much bigger problem than the money. We certainly think access should be one principle, but access has to go beyond money to think about the number of spaces available in terms of long-term care. So that's the first standard. The second one is the need to establish and enforce exactly what Margaret was talking about, minimum staffing levels based on the current research and based on verified data and assessment of social, emotional, and clinical needs. As Margaret said in relation to the report from the BC Seniors Advocate, it's clear that a lot of the data that we are getting can't be relied on in terms of especially things like staffing levels. So we need to make sure that we have verified data, that it is exactly what they claim it is. The third standard we have is a plan to ensure that 70% of the staff are full-time and that the remaining 30% be permanent part-time. We recognize that there needs to be some flexibility, but when you are creating that flexibility, you have to make sure that there are decent wages and sufficient wages for all of the people who work there in terms of benefits and sick leave and all of the other things that are absolutely critical to care. But we need 30% or at least a portion of the staff part-time so that there's some flexibility in the system and you can draw on those people when other people are away on maternity leave or sick leave or something else. So our fourth principle, it has to do with the physical environment. And Margaret mentioned the question of the 4-bed rooms. We certainly think we should be addressing those 4-bed rooms, and most provinces and territories now have a plan to do that. But the physical environment goes well beyond the size of the rooms, and we would say goes beyond personal protective equipment, which certainly is also part of the physical environment. But we need to think about things like the disposal of waste. We have to think about laundry. We have to think about the kinds of access there is for the community to the home and whether we can ensure that there is safe community access in terms of families and volunteers and other visitors. Our fifth principle is education and training. And we would argue that that education and training has to be developed and determined in combination with post-secondary institutions and with the organizations that represent those people who do the jobs. And that we would argue that that education and training has to be available to everyone who lives in, works in, and visits in long-term residential care. We have to have a broader notion of education. So our sixth principle, again, to some extent repeats what Margaret says, that we need policies that require transparent, verified reporting to ensure accountability to the public. And we have to ensure compliance with those standards based on those data and, of course, on inspections. And finally, well, I don't have to explain this one, make sure that we have a plan to only put public money into public or nonprofit facilities and services. And the services part is equally important, I think, so that we're not contracting out, subcontracting, as Margaret would say, the work of providing food or the work of cleaning, for instance, which we would see as an essential part of the care. So I want to move on to this question of a labor force strategy that is complementary to these standards, I would argue. And the World Health Organization said before COVID-19, the pandemic, workforce shortages, poor pay and working conditions, and low proportions of professionally qualified staff were already a major concern in long-term care. The workforce supporting people with long-term care needs is predominantly female, and in many countries, migrant care workers make up a large portion of the long-term care workforce. And of course, all of those things are true in Canada. So we think there should be a national strategy based on 5 clear understandings of what that involves. One is we have to recognize that this is skilled work, that it is true of the people who change the beds and the people who help people eat, and as well as of the people who provide clinical care. So we have to recognize that skills and the skills involved are clinical, social, and psychological. Second, we have to recognize, as we said over and over again in our research project, the conditions of work are the conditions of care. And those conditions, many of which Margaret has already listed, and I'm sure you know, have to do with everything from protection and safety and support to safe physical and social environments, and of course, decent pay, sick benefits, etc. The third factor is recognizing care as a relationship, and recognizing care as a relationship means that you have to recognize the importance of continuity and the importance of having staff who know each other as well as know the residents. And it's one of the things we've seen under COVID with the massive movements of staff among places, is that it's impossible to do teamwork. Fourth, we have to recognize that all staff members are part of the care team. And this is related to the problem of contracting out. If you contract out the healthcare services, they don't know the rest of the staff, and you fail to recognize how critical food and the whole process of eating is to care. We have to understand that it's everybody involved in the labor force that is critical to care. And finally, and obviously, that these standards have to be enforced through verified data and with real punishments if they are not met. So I'm looking forward to hearing from you on what kinds of concerns you have and what kinds of information you can share with us. Thank you.
Thank you so very much, Pat. And I do apologize for putting you in the wrong time era.
If only I was more technically competent, I could get it off myself.
It's why everyone needs a good assistant once in a while.
Rebecca, can I hire you?
So we've got quite a few questions coming in from the Q&A, and we have a few people submitting questions prior to the start of the event as well. And I think there's obviously there's so many complex issues here that are unfolding in front of us, but have been unfolding in front of us for several decades as well. So I think that's a really difficult thing to unravel here. And I haven't organized the questions, but I'll start with one here, more of a comment from Kathy, who submitted earlier. She just wanted to say that she had cared for her mother and father for 9 years in continuing care. I was there for 14 hours a day for a 10-month period of time. And that work from the family members who are essentially providing additional care to make up for what Kathy here, perceives as a shortage of staff in her experience, and that it's family members who are really filling those gaps, particularly around things like making sure their loved one is eating and drinking and walking and being social. So with it's maybe a question open to both of you off of Kathy's experience, how has the pandemic really impacted on that ability of family members to fill those gaps, and what's replacing that care work that has been provided by them?
Well, that's a wonderful description of the key role that family members have been playing for many, many years. You make a very good point that the sudden pulling out of that role due to the visitor restrictions, which I believe are present in most provinces, has meant certainly an exacerbation of staffing shortages. So where that sort of informal care was filling a gap, and indeed there were a lot of paid companions also that family members would hire, that was significantly reduced and certainly has led to some of the real crises in staffing. So thank you for bringing that up.
I would say that one of the things COVID has done, is doing, is making visible how much work family members have been doing for a long time in order to fill horrible gaps in care, from everything from brushing teeth to combing hair to no walks without a family member there, helping people eat. It's incredible the skills that they've developed, but the extent to which they do the unpaid work in the care home. And I think that we need to make sure that we use this occasion to argue that we have to be having enough staff so that we aren't dependent on family members to do this all the time. And I think it's made it visible and given us an opportunity to do this. When we were in Norway, the staff said, your family comes here so we can look after them. You shouldn't have to do that. And they even were paid to go out and buy things for residents. If a resident, needed some new clothes of some sort or whatever, the staff would go and get those on paid time. But we also were in homes in Norway that had where the staff to a resident ratio was 1 to 2.
I think that's a very good example of just the distance that we're trying to cover here between the Canadian situation and some of the best practice that you two have seen, particularly in the Scandinavian models. I'm going to combine here. Shannon and Anahi both have asked questions about staffing ratio. And Anahi asks, what's the recommended staff to resident ratio? I'm based on the most recent research. And Shannon sort of asks as well, what kinds of mix of skill levels and different roles within nursing and healthcare aid roles is the best practice within those staffing recommendations? And if either one of you might want to take the parts of that.
Well, I'll take a first stab. Generally speaking, most facilities across the country have ratios now that run anywhere from this would be on day shift, 1 care aide for 10 residents, all the way up to about 15 to 18 in worst case scenario. So, the best practice recommendation is almost to bump that down or double that. So 1 care aide to 4 to 8 residents. And again, depending on the needs, so there is a component of how much need a particular resident has. And there have been pretty sophisticated measurement of such needs, and trust the US to do actual time motion studies of how long it takes to feed a resident properly, to help them to go to the toilet independently. So it's a very empirical, science-based, and doesn't, of course, account for any capacity simply to chit-chat, to get to know a resident, to sit down and have coffee or sing a song or anything like that. But so bottom line, I'd say 1 resident to 1 care aide to 5 to 7 residents, and then adjusted upwards or downwards based on very sophisticated formula that now exist. I don't know if you have anything else to add to that, Pat.
I kept thinking about the chief medical officer or chief nursing officer for Canada testifying in a pay equity case said that they were trying to tell her that you could bathe a patient in 6 minutes. And she said, the only way you could do that is if you threw him in a chair, hosed him down and let him drip dry. That's the kind of time we are assuming now with these frail elderly people, as you were saying before. Charlene Harrington is the first author on an article that came out 2020 that has all of these details according to categories of staff. And one of the things that article says is that we should be talking about, if we look at it in terms of hours per resident per day, alternatively, that we're talking about more than 6 hours. And we don't have anybody in Canada that reaches the 4-hour one that is being talked about now as the minimum.
Yeah,
So,
in
a
British
lot more.
Columbia,
Pardon? Sorry.
in British Columbia, there's been a big push to get up to 3.36.
Yeah.
Many facilities up until the last 2 years being less than 3. So,
Well, the city of Toronto, for its 10 homes, has adopted a policy of 4 hours. The premier in Ontario, after the Long-Term Care Commission said, you have to do this and do it now, said that they have a plan to bring it in by 2024, which happens to be the election year.
May I just add something, Rebecca? In Alberta, we don't have any specific staff to patient ratio or hours of care that our seniors are being provided with. The only legislation that speaks to anything remotely close to direct care is the Nursing Home Act that talks about a 1.9 hours of RN care that they're supposed to be getting, but nothing else when it comes to healthcare aides or LPNs or any other mix of staffing. So like we often hear of sometimes, for example, in facilities where they're a designation of DSL4, which is just one step below long-term, and Pat explained, or Margaret explained what that entails in terms of care, that we have, for example, one LPN during the day for an entire building of over 60 people, and at night they're in charge of, one LPN may be in charge of 4 entire buildings, and nurses even less. So, there's definitely a need in Alberta to have standards put in place when it comes to the amount of direct hours of care that seniors get.
And that actually segues quite well into a question here from Wayne. And Wayne was asking about how BC and Alberta compare in terms of the hours of care per resident day. And his second part of his question is, do you think that this will increase after the pandemic? And I know, so you've both mentioned that as perhaps kicking the ball into the long grass, as Doug Ford has been, 2024. Margaret, you mentioned that BC has already been trying to catch up and get all the different health authorities up to an average of 3.35, 3.6. Yeah. But I guess my question there is that I've been digging through all of this stuff for a good number of months. Specifically, I'm not hearing those specific conversations in Alberta from our government, from our ministers. Where is that particular conversation about staffing hours, about care hours, specifically for Alberta in the pandemic context? Is there one?
I don't know the answer to that, but one of the reasons I think that there should be national standards is that it would really push all of the provinces and territories to go in that direction, but also it would allow them to share information on what was working and how it was working and why. I find it extraordinary that one of the premiers said, federal government, stay out of long-term care, because what do you know about it? And I thought, well, we could well ask that question right now of you, given what's happening in the long-term care homes in various places. And they're not attending to the kind of research we have. They're not attending to it at all. And I'm really afraid that what they're relying on is the vaccine, that the vaccine will stop this horrible death rate, and they'll figure that they've solved the long-term care problem. which they absolutely will not have. As the quote I read out from the WHO indicated, we had a crisis in terms of the labor force before this started. And we had that crisis because the conditions are so bad in terms of working in long-term care, not because it is innately horrid work. It could be very satisfying. And we did a study last year for the Ontario Nurses Association where we interviewed a lot of the RNs and registered nurse practitioners anyway, about what kinds of rewards they got in long-term care. And many of them found it a really great place to work if they had enough staff and if they had the right conditions. Yeah. And I'm just very afraid that we will not seize the moment on this and will not make the kinds of changes that we've known for years should be made.
On the other hand, it is a bit of a moment, and
absolutely,
even if the vaccine stops further deaths, there is a huge collective consciousness on the part of all those families who were not able to be with their loved ones when they died and when they were sick. And I think there is a kind of sense that we have to do something differently. So every province seems to be working on their own, oh my God, we've got to get this right next time, initiative. Everybody's going to have an inquiry. And so I do think it's a particularly ripe time for policy changes and to push through these really radically different staffing models from anything Canada's been entertaining over the last 2 decades.
I completely agree. And that's why I think, though, we have to be starting right now.
I know sifted through some questions here and I lost everybody for a minute. You're able to still hear me here? Sorry, there we go. I'm probably small children on the iPad, so I do apologize for that. There's a number of questions here about whether there's any research or statistics at the moment looking at the numbers of COVID-19 fatalities in Canada between the different profit models of facilities. And is anyone compiling that data specifically?
So there's nothing at a national level, but certainly Nathan Stahl has published an article looking at the different profit models. In their case, they simply looked, I believe, at for-profit, non-profit. Oh, they did have a chain category. But they looked at those models and found that for-profit models were associated with higher mortality and more severe outbreak. And when they factored in shared accommodation, the main group that floated to the top was for-profit chains that had something like a 70% higher, I'd have to look at it, higher rate of severe outbreak.
In Ontario, the Toronto Star has been doing some excellent work on long-term care. They decided to devote themselves to it, and they have produced a lot of data, comparative data on outbreaks. The outbreaks aren't so different. What is really different is the death rate. And they've gathered a lot of evidence on that. And the Ontario Health Coalition's been doing a lot of this collection of data as well and have produced similar reports. And there are also journalists who have been producing data on what contracted out management services mean. Contracted out to Extendicare or one of the other for-profit organizations, so that we've got this blurring of the line between what's a not-for-profit and a for-profit. But their data suggests that managed by a for-profit company is associated with higher death rates.
We do have a question here asking for a little bit more clarity around what is that line between private for-profit and private not-for-profit, and particularly with the situation here in Alberta where there are a number of they mention a couple of the religious organizations that manage facilities, or the ones that are subsumed under Covenant Health, and if there's any data that you can point to about how that not-for-profit model compares to fully publicly delivered care.
Well, I'll speak for BC, where the big difference in our world seems to be between the publicly owned and operated facilities and the nonprofits and for-profits. There's a smaller difference between for-profits and nonprofits that favor the nonprofits. But, you know, when we've looked at things like, you know, staffing levels, transfers to emergency room, hospitalizations, the biggest differences between the contracted out models, whether it be to for-profit and nonprofit versus the publicly owned and operated. That said, I think there's a huge and important role that nonprofit models play in reflecting the diversity of our communities. Many of the nonprofit models provide care that's tailored to you know, different language groups, different ethnic groups, different religions, and I think that's something that you don't want the state necessarily to have to sort of come and take over everything. And so I think that, you know, while the biggest differences are found between contracted and non-contracted, there still is a very fundamental difference, as witnessed by something like the seniors report that showed that the nonprofit models were still subsidizing care versus using the money to presumably make profit.
Sure.
We see from the data we do have in Ontario the same kind of pattern. I would suggest that one of the patterns, and to go back to what Margaret said earlier, we're talking about patterns and tendencies, not absolutes here, but that one of the patterns that seems to be emerging in this province is that the not-for-profits that are managed by for-profit companies aren't very different from the for-profit companies. The difference is in the ones that are not. Now, the other advantage I would mention is that their link to the communities are often very strong, these not-for-profits. And so you have a lot of volunteers and a lot of people who connect to the community in a daily and regular basis. That is not the case in the big for-profits. They don't have the same kind of sort of volunteer group or connection to community. You know, when the Ukrainian one here, the Ukrainians bring the kids in and they learn to speak Ukrainian from the elders in the home. You know, that doesn't happen in extended care in the same way.
Can I jump in here, Rebecca, with a thought and kind of a question to put to Pat and Margaret? One of the issues, this is related to the staffing discussion that we had earlier, is one of the issues Alberta's really struggled with is the risks that come with care home staff working in multiple facilities, or sometimes multiple jobs, and one of them might be in a care facility and one might be in a totally different sector. And that's largely due to precarious working conditions, including part-time positions, lack of benefits, insufficient wage levels. Just wondering if you could reflect on that issue, and also if you have information on how prevalent that is in other provinces. Is that the norm kind of across the country, or what does the picture of that look like?
Well, for sure, pre-pandemic, that was very much the situation, that often workers had to work across many facilities simply to make ends meet. often working, extraordinary hours per week. Then in our province, and I think also in a number of other provinces, there's a single site order that basically said facilities, the staff had to pick which facility they were going to work in. They would be offered full-time work in that facility, and their wages and benefits would be topped up to a sort of industry standard. So that has helped with that problem. But the single site order is considered temporary, and it's an order as opposed to, as Pat mentioned, having a high level contract that's considered a standard contract that all facilities would have to sign on with their workers. In the old days, we used to have one bargaining agency that basically came up with the same contract, whether it was for-profit, non-profit, or government-owned and operated, but that all fell apart in the early 2000s. But I think the extent to which you could get back to that staffing standard that's kind of baked into the care provider model is absolutely essential.
That's a major reason why we said in terms of a standard, you have to have at least 70% full-time, and that the permanent staff have to, that's part-time, that make up the other 30% that helps you get flexibility, would also have all these other benefits and had the rights to fill in the blanks when there is someone off on sick leave or whatever. But in terms of Ontario, we brought in such an order, as Margaret was describing, significantly later than BC did. But in addition to that, it didn't apply to agency staff. And agency staff are going in and out to multiple homes as well. And it didn't apply, as far as we can tell at least, to the services. So if the food service is coming in every day, it's a whole other set of people who are coming in, people who are often in direct contact with the residents. Similarly, when they do cleaning, which takes me back to what I was saying about how the concern is not just about infection, of course, to say, it's silly to say just, but it's the concerns are bigger than infections, because they don't know the residents. They don't know the agency workers when they come in. They don't know the other workers. And it often takes the staff that is there longer when there's someone that comes in from outside who doesn't know that Mrs. Jones, you have to take Mrs. Jones out of the bed in this particular way, or that in order to get Miss Smith to eat, that you have to be very careful because she will choke or she'll spit it out at you unless you do something. And they end up having to spend a lot of time teaching these agency workers those things, or tell them even where to find stuff that takes them longer. So it's more than a question of infection, but of course infection is absolutely critical. So if we don't continue to have this excuse me, work in one facility in place longer, then we're back to square one.
Just to kind of add that in terms of the Alberta perspective, in April, after we saw one of the first few deaths in continuing care, the chief medical officer put in a one-site order. Since that time, we've had so many exemptions granted, and now basically each of the continuing care providers are able to do their own handling of the pandemic and how they deal with staffing and who goes and who comes and where they can work. Alberta has given private and not-for-profit operators over $200 million to deal with staffing shortages and accommodation revenue losses. And yet that issue of making sure that people who are sick can stay home being paid wages, we're hearing all the time that staffing, when they're sick, they have to go on the federal grants that are available to people. And so this situation continues to be a huge issue here in Alberta, even though it's not talked about as much as it should be.
So one of the papers interviewed two personal support workers, care aides, as you would call them, who were living in a shelter because they were in such small wages that they couldn't afford housing in Toronto. Now that's a safe place for people to be living who are going to go and provide care.
It's shocking. I wonder if, sorry, that's pretty difficult to hear. If that, there's been a number of questions here about how can we, the collective we, push our governments to heed this evidence, the research that you yourselves have done, that others have compiled, and to learn from these failures. It seems like this information is out there. There's a number of these standards and best practices that are known and agreed upon, and yet it seems like some provinces in particular are going in the opposite direction. Not just Alberta, but we're seeing it here. So seems to be a big question among a number of our participants here. What can we do collectively to push governments to pay attention to the evidence? And also, what can we do as individuals to amplify those messages?
Amen. You guys are the organizers.
Right. Maybe that is it.
Back to yourselves. You know, I think we will do our best to generate the evidence, to both qualitative and quantitative. But the question is, you know, it's an organizing question, right? How do you harness this tremendous collective experience that we're all going through to build back better? And I think it is a moment that has great potential, and I think that there's a lot of consensus across the provinces around what needs to be done on the part of at least the community collective consciousness. So it's really a question of figuring out how to move that along the policy agenda to get it into practice.
When I get emails asking this question, and I get a lot asking that question, I send them to organizations like yours, as Margaret says. But that's also why we decided to put out this national standards. We figured that we need something to coalesce around. We need to have some kind of coherent set of demands that we can make nationally, and follow the model of the Canada Health Act by getting the federal government to say, if you want our money, this is what you have to do. If you don't want our money, fine. But if you want it, this is what you have to do. And I think that if we could get together and agree on what those standards are, and really pressure the federal government to move on this, I think that there's an opportunity there right now. They promised standards. What I'm really afraid of is that they then said we will negotiate with the provinces. We'll end up with what we have in other areas like home care. Here, we'll agree. You'll say, oh yes, we'll do this stuff. We'll give you the money, and it'll disappear. A whole lot of the money that's come to this province for the pandemic, we have no idea where it went. So we need to, I think we need to agree on a strategy together. And it doesn't have to be the standards that we set out in that paper, but if we could agree on that and really just coalesce around it, I think we could move.
So
Can I jump in on that too?
Yeah, Joel wants in.
Yeah, I mean, I think since organizations like Friends of Medicare and Public Interest Alberta, when it comes to the Alberta context, are so important for how we take action. And I would encourage everybody to see yourselves as connectors on these issues. And I think seeing it as connecting on two sides. So connecting to what's happening at the provincial level through organizations like us and staying in touch with what we're doing and participating in our actions, which at the moment are mostly digital. But as we come out of the pandemic, once we have a vaccine that's out there for everyone, we'll be doing in-person things again. And then, so connecting on the provincial level to us, but then connecting on the other side to people in your communities and making sure that your friends and families and neighbors and coworkers are engaged in these issues. And so that's where I think the research really comes in is, obviously we use it as organizations, but all of you can use the research too and the information you're hearing today to educate those people around you and put public pressure on politicians. And, we can vote out governments that don't do what we want, but that's not enough on its own. If there's not public pressure on politicians, regardless of the political party, then meaningful change just doesn't happen. So we need all of you, and we need you to engage even more people.
And I think that's a great point. I noticed a very neutral comment from the wonderful MLA Lori Sigurdsson in the chat there, mentioning, definitely write to your opposition MLA and ask them to put some pressure on the government as well. So I think that's good advice. She's offering to take those emails from you. So take her up on it. I think a good question, and I know, it's good to be critical and to hold our government's feet to the fire on this. There's a lot of difficult lessons here about what's going wrong. And a couple of people have asked about, is there anything that is going right, for anything that's working well in long-term care in the current situation? And particularly in Alberta, one of our participants has asked about, I think in reference to the, there was the Kai report on the OECD countries and the long-term care fatalities that showed Canada had by far the largest percentage of COVID fatalities from within long-term care, but that Alberta's number was in the middle of the pack. So does that mean that there's something that Alberta is doing differently, perhaps, than Ontario and Quebec to reduce our number of fatalities within long-term care? Or is that perhaps another factor in the statistics?
Yeah, it's intriguing. I mean, it would be really interesting to explore those are the fatalities within the long-term care sector, or the number of long-term care deaths out of the total deaths?
But that was the Kai data that was before the second wave.
Well,
Yeah.
I think at the moment, Alberta's percentage, now Sandra used today's numbers there, but the ones that were in the official release for Alberta yesterday stated at about 66% of the fatalities in Alberta were from among the long-term care or supportive living facilities.
So that is all positive tests as a denominator and long-term care fatalities. Is that right? That's what that was made up of. Yeah.
I think that question is like a mix of answers. I don't think we can point out being in the middle of the pack and having lost 978 as in comparison to how many people have died in Ontario. I don't think it's a good mark, or it should be. And I know where you're coming from, Rebecca. It's not a celebration that we have. There is a lot of things that are good within our system, and that's usually the care that most of the frontline workers provide seniors within the restrictions of how they have to work and the lack of support and resources that sometimes they have. And I would I would dare to say that that's mostly where all that comes from. And in Alberta, I think we always get labeled as being not very progressive. But when it comes to demanding things, we have a lot of experience at being good at demanding that we get what people deserve and need. And so I think in a lot of ways, the government has tread very carefully around the narrative around how many deaths we see or how they're reporting cases. We see all the time, one of the biggest concerns that people have in this province is how the pandemic numbers are actually being reported. And sometimes if you don't report them, they don't exist. The problem doesn't exist, right? We saw that how they're changing now, they're reporting numbers for school outbreaks. And so in seniors care, like I said, Initially, we were told where this is happening and which facility was having outbreaks and so forth. Now it's up to the operators to report that. So I don't know what we can kind of, basically say that we're doing this and that. And I think it's just a whole bunch of things. In Alberta right now, we have about 15,665 long-term care beds. 3,117 of those long-term care beds are semi-private. That means that all those people are sharing beds. So that's a huge number. So we've actually been very fortunate that we haven't seen more deaths. And like I said, I mean, what is the reason? And that's worth recognizing as well.
In terms of the question about what is good, we have seen some innovative strategies for sure developing, especially around the use of technology to connect seniors in long-term care with their families and with people outside. So there has been some innovative developments as a result of COVID, as there has been everywhere. And I think that the most important thing that's happened is to make people aware. As Margaret said, all of the kinds of issues that we've raised before have become really visible during this time. The Royal Society report has an enormous list about the number of investigations that have happened over the years, all of them saying the kinds of things we're saying here, you should do this, and nothing happens. Or we did a paper in our project called Is a Scandal and looked at, so what happens after scandals in the 6 countries that we were looking at? And what happens in North America after a scandal, if it's sufficiently important to get some kind of response, the most common response is more regulations. And those tend to be more regulations of the people who provide the care, rather than of the ownership that Margaret was talking about, or of the staffing levels that we've been talking about. And so you get more and more detailed regulations of what the person providing the care gets to do on a daily basis, which actually could have the reverse effect of improving the quality. But you don't get the larger issues addressed. So maybe the best thing that we can say about the COVID in terms of long-term care is now everybody knows. It's been truly stunning to me to hear reporters, or actually more importantly, people in the legislature say, oh, we have places with 4 beds. Well, yeah, haven't you been in any of them? And so a whole lot of stuff has become quite visible, like the staffing levels. And I hope, like the demands on the people who provide care. One of the other things I'm worried about is that when they want to hurry up to train people, or they want to call on people who haven't been working in long-term care, who are unemployed or whatever, and say, why can't we get them into long-term care to help, that we won't recognize the skill involved. We won't recognize how complicated it is to provide the care that is really needed in long-term care.
I'd just add that one other, I think, good things that has come out of it. And again, I don't have a good sense of Alberta, but in British Columbia and to some extent in Ontario, the public system has taken ownership of outbreaks no matter where they occur. So in BC, there was a model developed of these SWAT teams, which were teams of infection control, added staffing, palliative care expertise that would swoop in when a facility was on outbreak and literally meet daily with the facility leadership and try and address some of the issues and really pull a lot of resources from the public system and really see it as their problem, not something that, because it's contracted out, it's not in my job description. And I don't, in Ontario, that wasn't probably done in a systematic way, but you see these hospitals kind of taking ownership of their neighborhood long-term care facility and sort of coming in to help. And I do think that's kind of a good news story. I don't know how it's played out in Alberta, but it's certainly better than asking the military in. And it's definitely provides a cohesion to a very sort of urgent problem that is a good news, is a good thing.
I'm kind of combining two different thoughts here. So a few people have been asking about some of those really exemplary practices. I know that the both of you spent a lot of time studying the different Scandinavian models, and that we've also sometimes heard about, you know, there's this amazing home that's trying something really innovative, and or as you mentioned in Toronto, one particular home that's managed to get through the pandemic with relatively unscathed. So there are these examples of facilities or of models that do appear to be doing something right. Part of that question is then, how do we sort of operationalize those success stories into becoming the norm? And also, is there a place in that for these government initiated inquiries and review processes? And is that, you know, is that sort of just political theater, or is that a real viable mechanism for taking this from scandal to that success story and learning from those experiences?
Our project on reimagining was looking for good ideas worth sharing. So much of the time as researchers, we look for the bad stuff, right? And we did find good things in Canada as well as in countries outside Canada. We also saw some bad things that we learned from, it has to be said. But just as one small example was, and it relates to one of the standards we suggested, was in Manitoba. There was a home that had all of the staff were their own staff, part-time or not. And they used the part-time jobs as the way not only to fill when someone went on vacation, but as a way to fill their full-time jobs when someone left. They acted as a whole team, and that included the people who worked in the laundry, the people who were the cleaners, the whole place. And one of the things they did in their training, and this one man who was a care provider, who was part of this training in the home, said that they made him have experience getting put in a lift to have a bath. And he said, it was the most incredible training I could have. He said, they even let me keep my bathing suit on, but it's still the kind of exposure and the helplessness you felt under that kind of situation was just such an incredible learning experience. So I think that there's a lot of things we could learn from each other if we looked during this pandemic at who did it right. why did they escape? Now, they might have escaped, to go back to something Margaret said earlier, because nobody in the community had it, you know, and I certainly know, I grew up in Northern Ontario, and I know that there are several small towns in Northern Ontario where there hasn't been COVID, and where the long-term care facilities have been okay. There isn't any COVID, so that could be one reason. But there's got to be other places in the center of cities or in across the country where we could learn. And that's another reason why we should have some kind of national coming together around this, to figure out, yeah, what did work, where and how and why.
Right. Do we have time for one more? Are we right on? You think? All right, we'll go for another one here. Okay, so a couple of questions here around the role of a dedicated seniors advocate. I know that you in BC, Isabel McKenzie has been very proactive and sort of spearheading quite a lot of the research and the reporting around the state of long-term care and seniors care generally in BC. Alberta did have a seniors advocate until about a year and some months ago. Is that something that we should be pushing for, is a dedicated office to sort of hold government accountable specifically on seniors issues, or that there are other avenues to have that voice for seniors to be heard more effectively?
I mean, I find our seniors advocate has played a very, very positive role. And the nice thing about seniors advocate is that she can access data and information. She has staff that can do analysis, and it's kind of a protected position. So I think if it's been cut, it should definitely be reinstituted. In Alberta and elsewhere, I just think that any community is vulnerable as a long-term care and seniors population more generally. It lends itself very well to having an independent advocacy sort of operation.
But a lot depends on its independence, and a lot depends on who.
Absolutely.
It's a really important one here, I think, around COVID deaths and how whether any of the provinces are looking specifically at excess and collateral deaths in long-term care and continuing care that might be due to the pandemic conditions, but not directly attributable to COVID, and sort of who's doing that work and what we might learn from it.
There is work going on around that. I don't know who's doing it, but certainly it's come up, you know, at research tables. So not just related to long-term care, but more generally, but in long-term care, you can see why it would make total sense that seniors who've been cut off from their families, who may be eating less, have less stimulation, may just kind of turn over and die because of loneliness and other kinds of neglect that's unrelated to COVID. So I think it is a really important line of research. And again, it would be something to advocate for, that governments commission, you know, a detailed report that provides good analytic statistics on this.
I know Pat mentioned way back in her discussion earlier on about the importance of those support services. And I sort of fumbling here because you said very, very clearly to start to reconceptualize dietary and housekeeping and laundry as care work and as integral to the importance of delivering care, which I really agree with you. I need a language for that. Someone's asked here specifically about the role of dietary services around quality nutrition, and what we're seeing with a lot of the sort of in crisis homes that have sort of made the news, with malnutrition and dehydration among residents. There's also been some images going around on social media showing little containers of breakfast that you just cringe to see, these sort of what's being offered to our elders in some of these facilities at the moment. Is there that the two of you could speak to how we can improve the food situation and how important that is?
Don't contract it out. That's rule number one. And rule number two is having staff that actually knows the residents, gets to know who those people are, what they like to eat, and how they like to eat. Those are really critical. We just recently studied a home in Ontario where actually it's connected to a hospital. They had contracted out the food, and but they managed to keep their kitchen, which many of them don't when they contract out the food. And there was such a backlash from the hospital, from the staff, from the residents, from everybody. They had to bring it back in-house. And this kitchen is award-winning now. Now, isn't that unheard of in a healthcare facility? But the staff know the residents and have really figured out what they like to eat. So we were in a similar place in the Maritimes, actually, where and we have to think about this. Food is the main event of the day. It's social. It's really a social event. But also, you need your appetite stimulated by the smell of food cooking, or and by other people around. But also, one of the things that we saw a lot was residents rejecting a whole big plate of food that is put in front of you. It's too much, and they get turned off completely, or it has something they absolutely hate in the middle of it, and so they can't eat it. And it's the kind of thing you can deal with if you know the residents and if you cook on site. You can't, if it's being brought in. I actually had one policymaker say to me, well, this food that's being brought in is just like on the plane. And I'm thinking, yeah, that's true. It's just like on the plane, but maybe you and I sit in different places on the plane. And you get that day after day, right? So I'm even if they are providing people with food, I'm not surprised they're not eating. And of course, then you add to that people need to be assisted. And in Ontario, when the military reports came out, they talked about people finding people with the food still in their mouths, with people not eating at all, with all kinds of problems. And it partly relates to the fact that we think, oh, if we did some of the clinical, then the rest of it isn't a big deal. But it's actually absolutely central to surviving, and certainly to surviving in decently and effectively. I'm sorry, I'm really, we ate in all of the places we were into at great sacrifice in some cases. Margaret probably has something to say.
No, I just say here. I remember you looking at this pile of sludge at that facility in Vancouver that we were doing a visit to. Mystery
food.
Yeah. Rebecca, you haven't read my direct messages, but I'm just thinking we don't have enough time for any more questions. So I wonder if we can give our panelists a bit of time to wrap up their presentations. And then.
I was so busy reading all the questions, I didn't get a chance to read Sandra's. I'm so sorry. There are so many very, very good questions here.
Yeah.
So
Thank
And
you.
just so that you guys know as well, what we'll strive to do is actually take those questions and answer them via email. We'll send them to whoever they were directed to and get as many answers back to you as well. Any of the links that were shared and resources that were shared tonight, as well as previous to this webinar, that we will also share that with you as well. And if the presenters let us share their presentations, we can also send that as well.
So if you had to wrap up, and you wanted us to come out of here, each of you, with the most important thing for seniors care right now, and what would that takeaway be for us tonight? And we'll go in reverse order here and start with Pat for a minute.
Seize the moment. It's up to all of us, as Joel said. And thank you all for being here.
Margaret.
Yeah, I just echo Pat. I think it is a moment, and you know, some of probably the most important issue would be to come up with a staffing standard that's science-based and that follows the evidence. And you know, our governments are very big on talking about evidence-based this and that, and yet they've been ignoring the evidence on this question, and it's time we pay heed, because I don't think this is going to be the last pandemic. I would love to think so, but we have another climate crisis that's tends to like to generate these kinds of viruses.
Thank both of you so very much for sharing your experience and your wisdom with all of us here today, and helping us to make some sense in this increasingly nonsensical timeline we're in, and helping us to be better advocates for the older people in our lives and in our communities. And I'll let Sandra or Joel take us out.
Petra, thank you so much again, Rebecca, for agreeing to moderate this. This was an incredibly informative presentations that we were able to listen to. I just want to encourage all of you to join us at abseniors.ca. That's the website that has all the information, and we will be posting the video from this webinar in that site, and anything that we will be engaging in, both from Public Interest Alberta and Friends of Medicare, will also be on the website. Join Friends of Medicare. We're also working along, as Pat indicated, she's a member of the Canadian Health Coalition. We work with the Canadian Health Coalition as well in terms of pushing nationally for a standard. There's a lot of work that will need to be done. We can't do it without your support. In presence of, please join us in this time when we need to make sure that all our voices are heard on behalf of all those that don't unfortunately have a voice. I think we need, like Pat said, to seize the moment and come out of this pandemic stronger, and with the ability to imagine that we can do so much better, and that we can't allow ourselves to go back to what we had in place prior to this pandemic. So thank you so much. Joel?
Yeah, I just want to echo what Sandra has said, and also thank Rebecca, also Pat and Margaret and our staff, as well as all of you for being such a great engaged audience. Just reading the chat through the whole thing and hearing the questions, it was very clear that you're all very passionate about these issues, and all of us have something to contribute to this, and to pushing for solutions to the problems that we all see. So please keep it up, and we look forward to seeing you virtually and eventually back in the real world again.
Thank you. Good night.
Bye.
Bye-bye.
Night, everyone.